full of specialists. But I think what I like about Dr. Mohan is this is a person who not only is phenomenal in the care management system play, but also in research and charitable needs. Over 1,500 papers published, number of book chapters. I think that you can read about it, and especially for those who are affiliated with academic institutions, please do look up what Dr. Mohan and his team have been doing as part of the Research Foundation, MDRF. Uh, I think the other piece is clearly around diabetes management. This is a person who manages it along the long chain. And I want to make a significant distinction because we'll go through it in our discussion with Dr. Mohan as we enter the chat and asking questions. What is the fundamental difference between many folks asking very short-term perspectives versus... Guys, can you see me? My camera is frozen.
No, we can see you. We can see you and hear you.
Cool. And just understanding how to manage the different types of diabetes. Obviously, one, there are temporary reprieves from, one you can perhaps lifestyle manage, but some you can't do anything about. And I think understanding the difference between those, as well as some of the latest advances, is what Dr. Mohan is going to provide us with deep context. And I think without that, I mean, he's won more awards than and lifetime achievement awards. So I joke about it. The number of lifetime achievement awards you get are the amount of dissatisfaction you get at home. But I've been told that he actually keeps a lot of satisfaction at home as well. So more important than anything else, this is supposed to be highly interactive. Please ask us questions. You get what you put in. We will moderate. So if there is a very easy question, I might field it with my hand, but otherwise I'm going to let the expert take most of the pain. And I think with that, Dr. Mohan, the floor is to a large extent yours. I don't know if you want to say some opening remarks and then perhaps put some slides up if you have. Otherwise, I can go straight into Q&A.
Yeah. Thank you, Dr. Samir Mehta.
Just call me Sam, and I'm not a doctor. Let me be clear.
Okay. It's mentioned as Samir, Dr. Samir. Okay. Thank you, Samir, and thank you to Sumitra and the whole team. I have participated in other programs with Muthu and others in the IIT Madras HTIC MedTech Incubator program, but this Ask Me Anything series sounded very interesting to me, especially when you have young minds at the IIT Madras, and that's why I agreed for this session. No, I do not have any slides, but just to set the ball rolling, I thought I'll give just a few opening remarks, and then we'll give more time for Q&A, because I think that's what the whole thing is about. Ask me anything. It's not me giving a lecture. So the first thing that I wanted to say, as Samantha said just now, is that a couple of things you have to keep in mind. Number one is diabetes is increasing very rapidly in not only in India, but all over the world. Why I am saying this is because even this was challenged and is still being challenged. I don't want to mention names. I have very strong views against people who talk pseudoscience. But there are people who say there's nothing called diabetes and it's all made up, and pharma people are making this up, and people like Dr. Mohan are making it up just to increase their business and things like that. Nothing is further from the truth. I have been in this field for 50 years now. I may not look that old, but actually I've been in this field for 50 years. And when I started with my late father, the diabetes prevalence is 1%, 2%. Today, in whole states of India, I'm not talking about cities, I'm not talking about Chennai or Delhi, in whole states of India like Kerala and many other states, Goa and so on, the overall prevalence of diabetes is 25% across urban, rural populations, which means 1 in 4 people in Kerala has diabetes today. Not in Trivandrum or Cochin, but throughout the whole state. So this is where diabetes is heading, and we have almost an equal number, slightly lower percentage of pre-diabetes, which means the epidemic is not over, and it's still going to keep on increasing the numbers. Very soon we'll hit. Today we are told we have 74 million people. I think that's an underestimate. That's based on one of our own studies where we did the northeastern states first and published that they had lower prevalence. Based on that, a very conservative figure IDF put out. In fact, in 2019, they said we had 77 million. In 2021, they said we had 74 million. They depromoted us and said you got 2 million less now. Whereas in China, they added about 40-50 million people. I don't know how they do all these figures. But anyway, that's a lot of people. Even with 74 million people, it's more than the population of France or Germany or UK, and 3 times Australia's population. So that's the number of people we have with diabetes in India. And again, as Mr. Mehta very rightly said, diabetes is not one disease. In fact, it might surprise you to know that at least there are 40 to 50 types of diabetes. So the only thing common is high glucose level. But once you have the high glucose level, there are about 40, 50 different types of diseases which are bundled under diabetes. Type 1 is one example, where you get it in children. If you stop insulin, you will die. There's no other treatment for type 1 diabetes other than insulin. You will hear that Ayurveda can be used or something else can be used, or reversal therapy for type 1 diabetes. They'll all die. Those children will die and you can bury them fast. If you stop insulin, even for 24 hours, 48 hours, you stop insulin, the children will die. I've had experiences of them going away and trying Siddha treatment, and 3 days later, father telling me a child died. I say, I think it's murder. If you take a child off insulin and offer a quack treatment, it's equal to murder. But then there are type 2 diabetes, which is 90-95% of all the diabetes we treat, where in early stages, prevention is possible. Reversal is also possible. So if you've got overweight and you're obese, you're type 2 diabetic, just diagnosed with a very strict diet exercise program with definitely weight loss, you can reverse it. But then the problem is, how long will you reverse it and how long will this weight loss last? Because people put on weight again. All of you who have tried weight reduction, I'm sure will agree. You can lose 10 kilos, but then you'll put on 15 kilos after that. And this has been going on for ages. And that's because nothing has changed in human beings. When you see diet, we feel like eating, and with all your control that you have, the regimen, after some time you will lose it. So that's type 2 diabetes. Then there's pregnancy-related one called gestational diabetes. There are types of diabetes associated with stones in the pancreas called fibrocalculous pancreatic diabetes. There is neonatal diabetes which occurs in children below 6 months of age, which incidentally doesn't need insulin, can be treated with tablets, but you need genetic testing for that. There's a type of diabetes called MODY, maturity onset diabetes of the young, often mistaken for type 1 diabetes. If you do a genetic test, and we are a official lab of the ICMR to do this, and if you find out that you have MODY type diabetes, it's not MODI but MODY, then you can stop insulin and change that person to tablets. So it goes on and on. There are many genetic syndromes, and there are exocrine secondary diabetes, endocrine diabetes, all kinds of diabetes are there. But for simplicity's sake, let's take type 2 diabetes as the main focus of discussion, although I hope you'll also ask me questions about type 1 diabetes, because I think type 1 diabetes, if we really get our act together, we can work towards a cure. Or if we don't work towards a cure, at least we can find technology to control it well. Today, that technology is very expensive. You have pumps, and you have artificial pancreas, and you have continuous glucose monitoring, all imported and at a very high cost. So there's lots that Indian engineers and scientists can do to alleviate type 1 diabetes, and some insulin requiring type 2 diabetes as well. Now, the problem in India is that we all work in silos. Doctors only think about diabetes. I only think of insulin. I don't think of something else. Engineers think of something else, but they don't talk to the doctors. So I think in countries like US, where MIT and Harvard will work together, they are able to find solutions because the interdisciplinary work is very common. In India, we don't tend to do that. That is why when IIT Madras invites medical people, I feel very happy that, oh, here is a window of opportunity being created. So I hope some of the young minds in the audience ask the proper questions, and I can go on, but there is lots that can be done. All I can tell you is that today I have patients who have completed 60, 70 years with diabetes, and they're doing well. Some of my patients have crossed 95, 100 years of age, and they're still alive. Some are 101, 102 years old. I don't think my father 25 years ago would have thought it's even possible, but today it is possible. And I call it as ABC mantra. Your A1C, that's A, blood pressure, B, C is cholesterol. And D, of course, stands for discipline, diet, exercise. If you follow the ABCD mantra, people can live a long and healthy life, whether they reverse it or they don't reverse it. Of course, reversal has become a big thing. We can talk about it. I'm not talking about it now, but in question time, please ask me. Already, Ms. Mehta has suggested about reversal and short-term treatments. So there are lots of things to discuss, and I'll stop here in the interest of time. And now you can start shooting your questions. If I know the answers, I'll tell you. I can't profess to know everything. There are many things about which we don't know the answers. And if I don't know, I'll frankly tell you I don't know. So on that note, I think over to...
So let's set the context a little bit with, before we jump into questions, with perhaps the trends, because it's very easy to go down a rabbit hole with what we know something a little bit about.
Yeah.
So perhaps let's start with the breakdown. There is obviously the diagnostics or the evaluation of diabetes.
Yeah.
There is the treatment in terms of both drug-based as well as, let's say, and I think there's a clear question, non-pharmacological approach to management. And the third is long-term rehab. I mean, I can tell, managing a hospital, we're celebrating our 90th year next year, that diabetes, when you get it, and we have a very strong pediatric program in Dr. Mehta's, clearly the degrees of freedom are disproportionately less than if you didn't have diabetes, right? So your degrees of freedom through your life diminish in terms of the treatment protocols available to you at different points of life. When you're young, you can manage it and have a great, fulfilling life, as Dr. Mohan said. When you're old, you can also have a great, fulfilling life as long as you control certain factors. But your degrees of freedom, so when you have a heart attack, when you have strokes, if you have diabetes, the range of options you have diminish dramatically. And I think that is one thing you've got to take into account, that if you're privileged not to have diabetes or the opportunity to delay it as much as possible, please do take that special ticket. If on the other hand, you are hereditary going to get it, or you're born with it, or you have no consequence to getting it, then of course the reality is you've just got to manage it very carefully within your own parameters. I mean, the hard reality is sometimes we diminish the quality of life to control, and sometimes we are able to manage it without diminishing the quality of our life. And I think keep that in mind. But let's go back to the base question, which is the different trends that we're seeing, whether it's in diagnostic and measurement, whether it's in the treatment protocols. We'd love to hear your views and things around smart insulin, radiation therapy, some of those points.
So let's start with diagnostic thing. And having lived 50 years in this space, and complete 50 years, I have seen it all. Many of the modern generation, including my daughter and all, may not even have seen some of the things which we did in the past. For example, when I started with my father, we had only urine sugar tests. We didn't have glucometers. Glucometers came much later, maybe 10, 15 years down the line. The first glucometer came, which you can put a drop of blood, and then actually you need much more than a drop of blood then. And it gave you highly erroneous readings. It will be 100% wrong. And you have to wash it and then cool it, and then, for 5 minutes you wait, and then you'll get a terrible answer which is totally wrong. So from that phase of urine sugar, old Benedict's tests, then dipsticks to find out whether the sugar is there, and ketosis, you can check with a strip. From there we went on to glucose meters. Then those glucose meters got better, faster. Today in 4 or 5 seconds you can get a reading which is very accurate, almost equal to the lab. We call it as plasma calibrated meters. But then they still give you only a snapshot. If you check the sugar now, it tells you what it is this second. It doesn't tell you 5 minutes earlier or 5 minutes later what it's going to be. Then came the continuous glucose monitoring. Now, when I worked in Germany in 1985-86, my boss had such a great vision. He had already thought of continuous glucose monitoring. So he made me work for a whole year trying to find out continuous glucose monitoring. And sad to say, we totally failed. And then he said, he was my father's age and contemporary. So he said, no, this is never going to come. And after he died, continuous glucose monitoring came. Today it's got so simple that you put a small patch on your arm and it will continuously read glucose readings, more than 100 readings in a day, 14 days, 1,400 readings. It gives you all kinds of graphs. It will tell you what percentage of time it's under control. It's such a big step forward that today, without continuous glucose monitoring, we virtually don't treat diabetes at all. Just like the fasting sugar, postprandial sugar, Then came the HbA1c test, the 3 months control test. When that came, that was a kind of revolution, because in 3 months, what your sugar is, you can find out with just one reading. Now that HbA1c test, when I first started with my father, it used to take 16 hours to do it. So we now used to get it the same day. We'll get it the next day. By the time patient is gone. And those days, no email. So we have to post it to them. They'll get it after 10 days, the result. Today, in 3 minutes, you can get HbA1c test. So I don't see any patient without a HbA1c test. If they come in the morning without HbA1c test, I don't even see them. So things are changing so far. So from fasting post-meal blood sugar to HbA1c to continuous glucose monitoring to various, these continuous glucose monitoring now being linked to pumps which deliver the insulin. We call that as artificial pancreas. The whole cycle has now come, and the accuracy of these has improved so much that you can actually depend on them. So in the diagnostic field, almost now, even just like you have, earlier for to take the temperature, you have to put something in your mouth. Then came thing today with the infrared thing. When COVID, everybody knows that you can just stand away in the airport as you're entering from a photograph. They take and they tell you your temperature. So like this, things are moving. Today, contactless blood sugar readings are also coming. Just like you put a pulse oximeter thing, you can put it there and you can get your reading of blood sugar. So things are getting better and better and better every decade and every passing year. So the diagnostic accuracy has improved. As far as therapies were concerned, the first treatment which first came for diabetes, apart from our herbal treatments and so on, which we had 100 years ago, was exactly 101 years ago when insulin was discovered. It took another 30 years for tablets to come, the first sulfonylurea and metformin. And for the next almost 50 years, we had only those two tablets, metformin and sulfonylurea. So for me to give a talk on oral drugs, very easy. Just talk about metformin, talk about sulfonylurea. Today, we have about 8 different types. We know that there are at least 8 to 10 different defects in type 2 diabetes. So you have defect in the kidney, defect in the liver, defect in the adipose tissue, defect in the muscle, defect in the alpha cell of the pancreas, beta cell of the pancreas, defect in the intestine, defect in the brain. So you have so many defects. And for each of them, you have tablets now. So it's not that everybody has to take 8 tablets, but there are some which have 4 of those getting covered with 1 tablet. So with 1 or 2 tablets, you can cover almost 8, all the 8 defects you can cover. So today it has come to precision diabetes, precision diagnosis. You're able to make a precision diagnosis, identify the type of diabetes, identify the type of defect. Let me just take type 2 diabetes. Type 2 diabetes, we used to treat everybody in the same way. Give metformin. If that doesn't work, add sulfonylurea. If that doesn't work, it's like a lottery ticket. You take one, that doesn't work, take another one, that doesn't work, take something. Today, about 2 years ago, my daughter and I, we published a paper classifying type 2 diabetes into 4 types. One is a young onset insulin dependent, insulin deficiency being the main thing. The other is an obese insulin resistant type. Then there's a combined type. And then there's an age related type. Now the 4 type 2 diabetes are treated in 4 different ways. One will need a secretagogue like a sulfonylurea or a DPP4 inhibitor. One will need metformin or SGLT2 inhibitor. One will need both because of combined defect. And the old age related one, you can treat with anything. Just metformin is enough to treat. So you can see that how 5 years ago, I would treat it all type 2 diabetes in the same way. Today, we're able to subclassify it. So more and more into precision diagnosis and precision diabetes are going. And not all these are expensive. To classify those 4 types of diabetes in type 2, you don't need genetic testing, don't need anything. Simple clinical parameters using HbA1c, BMI, family history, you can classify that. The weight of the individual, you can classify. So this is where in each of these, for example, if there are people in the audience who are artificial intelligence specialists or deep learning, machine learning specialists, you would be able to do it better than me and say, Dr. Mohan, I can tell you using these parameters that this patient is having this particular type of. In fact, we developed a tool now called Diana tool, an app. We just put in the characteristics. The computer will tell you this is this type of diabetes and you can try this type of treatment. To that extent, we have gone. So I think more and more interdisciplinary collaboration with people like IIT and others is where medicine is heading. Of course, in the olden days, the clinician thought he knew everything. Often they were wrong, but you couldn't question them because they were big professors. Some of my professors used to make horrible mistakes, but there's no way of checking them because they had such an aura around. Today, you can just tell them, sir, you're wrong, because here I have the thing to tell you it's wrong. So today we can't be as dogmatic as some of my teachers were. So that is how I think things are moving. I think now you can take the questions, sir.
Yeah, absolutely. So let's jump into the first one that I think we've already. So let me bring up this controversial topic, the non-pharmacological approaches to management of diabetes.
Yeah.
Let's hit it. So we're seeing a lot of venture-funded startups, a lot of, I would call it diet-first kind of players, folks who promise, which sounds a little bit like snake oil, that you can reverse diabetes. Would love to hear your views on what you see as some of these.
So it depends on which type of diabetes you're talking about. So if you're talking about type 1 diabetes, I think you're doing a disservice because the child will die. And I've heard in some of these walas, I call them as walas, the cure walas. So these cure walas claim that even type 1 diabetes they can cure with diet and so on. I would, with folded hands, I would tell them, please leave these children alone. Don't kill them. And don't, and then they also say, even if kidney is damaged and in renal failure, they'll reverse the diabetes. I'll say, please don't bluff. Please don't lie. There are places where you can contribute, but please don't extend it just for you to make more money through your P's and all that. Don't do disservice to a profession which is noble. But having said that, as I said, there are type 2 diabetes, especially in early stages type 2 diabetes. There is a stage of normal glucose tolerance, there's a stage of pre-diabetes, and then there's early diabetes. And then, as you said, later on when all the comorbidities set in. So in the early stages, we have now evidence that in the first 6 years, you can actually attack that problem. And there you can try for this reversal, particularly if you've got a lot of weight to lose. In a thin person, you will not be able to reverse, because what are you going to lose? Just by cutting off carbohydrate, you will not be able to do that. Now, is dietary treatment and is exercise and non-pharmacological important? It's probably the basis of treatment of type 2 diabetes. So we cannot get away from the fact that that is very important, probably more important than taking drugs. We allopathic doctors are also to be blamed because we leave that alone completely. I tell all my allopathic doctors, why all these walas are moving in? Because you're not even talking to the patient about diet. You're not telling them anything. You're just prescribing one drug. When that's over, you prescribe another drug. You prescribe a third drug. You're not even asking, have you slept well? Do you have a family? Do you have a fight with your wife? And is that why your sugar has gone up? You're not asking simple questions, which these guys will spot and they'll do better than you. So we must treat everything holistically. And there is a large lifestyle component. Stress is a very big factor. So if you introduce yoga and pranayama into this, you'll find a lot of these stress-induced diabetes, stress-induced blood pressure coming down. If overweight is a problem, then you have insulin resistance. You have to crack it. You have to reduce it. You have to put people on a calorie-restricted diet. In our country, that will be a carbohydrate-restricted diet. But that doesn't mean zero carbs, as many of the others do. Keto diet, this diet, that's the other extreme. That's a fad. You cannot survive on that, and it's not even balanced. You'll end up with 80% fat diet. You must just cut down. Hopefully, we just yesterday night, we have got fairly good response from a very, very top paper which we have written and sent to Diabetes Care. We didn't even think it'll get into that, where we are suggesting mathematical modeling. How much of the carbohydrate has to be reduced? How much of the protein has to be increased? Based on our in-depth study in the whole country, we have modeled it, but it's pure mathematical modeling paper. We thought it'll get thrown out. But they are very excited and they said, okay, make some little tweaks. And once that comes in, we will put it to the nation, to our health ministers and so on, and say, this is what needs to be done. Slight reduction in carbohydrate, maybe even 10% reduction in carbohydrate, and say 5 to 8% increase in protein can reverse diabetes. Can from pre-diabetes can go to normal. From early diabetes, you can go to pre-diabetes or to normal. And if, of course, calorie restriction is a must, and you must lose weight, especially in those who are overweight. So there is a big role for this to be done. And if some of these guys are using technology to do it, or using apps or something else to do it, so be it. The only issue that I find with it is that they overpromise and underdeliver. And number two, it's not sustainable. And third, it's all done with a commercial bent of mind, which I don't blame them, because they are in the business of making money. And most of it is commercial. And people, are, when you tell somebody that you will go off medicines, you're going to get cured. You know what that person thinks? he's thinking of all the gulab jamuns that he can take. Okay. So that person is telling himself, Dr. Mohan will only give me metformin or something. This wala is going to give me something which will take me to heaven. Not literally, he's not going to die and go to heaven, but heaven on earth, where all the gulab jamuns that he wants, he is going to get. Forget it. You're not going to eat one gulab jamun, because that's going to bring back your diabetes. For the rest of your life, you'll eat no gulab jamun. For the rest of your life, you will cut down on your carbohydrate. For the rest of the life, you will exercise. For the rest of your life, you'll be eating healthy. You will be eating more vegetables. You will be eating more protein and fiber. And if you do that for the rest of your life, yes, you can do that. The problem is only 1 to 2% of people come under that paranoid category, where they will continue to do that. One of my professors, I had lunch with breakfast with him, and I saw him take a slice of bread and cut it into quarter. And he was taking quarter slice of bread. So I said, sir, you're cutting it into quarter. Can't you take half at least? That will be too much. He said, it will be too much. So he's taking quarter slice of bread. That was his thing, you know. So there are people like that who will stick to this, but that's a very small percentage. Most people will try it, then they'll go on social media, like the before after pictures of weight loss that you see with some companies, and they'll say my HbA1c was 12, now it is 5.2, and everybody is happy. A few more customers, they get into it. After 3 months, it is HbA1c is 9.2. He'll never tell you that. That is reversal of diabetes. Will anybody be bold enough to come and say, no, now I am out of it, and now I am come back, my diabetes has come back? They won't tell you that. We see that all the time. Okay. So we talk about that as reversal of diabetes. So it is good. I'm not saying there's anything wrong with it. It's very good. Take it. But whatever you do, my advice is, unless for the next 10 years you're going to do it, don't even attempt it. Don't, and I always tell people, unless you're getting married and your fiance wants you to lose some weight and next 3 months you want to do that, then you go ahead and do that. You look nice on your reception day, standing there. But otherwise, don't do it just for 3 months and 6 months. You'll probably do more harm, because the body is used to a certain thing. Then yo-yo effect, you bring this down, then again it goes up, then again bring it down. Again, you're setting the parameters so often, you're changing it, body will get confused after that. It won't respond to anything. If it had remained at that level, it may not have done that much harm. But doing this yo-yo effect will probably harm you more. So if you're going to do something for the next 10 years, go ahead and do it. That would be my advice.
That's excellent perspective. Just building on this commercial discussion, clearly, I think there is a significant bandwagon of folks around the drug industry setting benchmarks of what is called diabetes. I mean, we've seen that in cholesterol, whether you've got cholesterol or not. And therefore, when do you start taking metformin or some of the other very expensive drugs for life? And that seems to be a big reason for a lot of these walas to pop up out of the woodwork, either structured walas or unstructured quacks. I think that's part A. The other part is I'd like to talk a little bit around the patch, because there's nothing stopping a patch that could be made domestically that stays on a person for 365 days and that provides much more high quality data rather than the 14 days of nirvana and temporal.
So I wish somebody who is listening here in this audience takes it up. I don't think a small patch like that with a hair-like thing, which is a sensor, which is hardly weighs a few grams, to develop that in India when we can send rockets to the moon. I think developing that kind of a thing, I think, should be peanuts for for an intelligent mind. So I hope one of you who's listening takes it up. It would be fantastic. This 14 days only, earlier it was only 4-5 days. When it came to 14, it seemed to be a big thing. Why not make it 2 months, 3 months, 1 year that you have? Of course, there are some implantable ones where you open up the skin and then put it in, and 6 months it comes. It's too invasive. I wouldn't touch one patient of mine to open up their skin and put something in which will produce fibrosis or a reaction or an inflammation. So right now, nothing invasive I will get into. But if this patch can be made even 1 month, why go to 1 year? Make it 1 year, 1 month, 2 months. And then if it's India made and you can reduce the cost even 50% of what it is, I think that would be great. Talking about pumps, today we have pumps which are good. Of course, we have only one supplier in India, and that's Medtronic. Okay, all others have left the field because they couldn't get enough thing. Now, an ordinary pump costs 2 lakhs. Okay, 2 lakhs and buy a car, And what is this pump doing? All it's doing is a battery which is driving the insulin. That's all it is doing. I think you should make it for 20,000 rupees. Somebody should be able to do that for 20,000 rupees. You think in India, you can't make a small thing which will drive a pump, a syringe to be just driven, and you can't do it for a lower cost? Surely there is somebody there who can do that. Now, with artificial intelligence built and all that, there's a very nice system which recently introduced Medtronic, about 6 lakhs. It's very good. It's an artificial closed loop, artificial, hybrid artificial pancreas with a closed loop system. It's very, very good. You put that for 2 days, the system studies your own blood sugar, uses AI, and then automatically adjusts the insulin doses. It's been very good. I've tried it in children also, and it's working very well. But 6 lakhs, for that. Why can't we learn the technology? And you think there's not enough AI people in India, or the small thing to make it in India? This is where I think the Walas should get in and then start making it and say, well, we have one for 50,000, which works just as well. And I'll give you an example. It's impossible. See, when my wife first started, our retinal camera used to cost about 20-25 lakhs. We couldn't afford it. When I was with my father, 25 lakhs was a huge sum of money those days. We couldn't buy. So she used to take her patients all the way to Vijaya Hospital, where Dr. Babu Rajendran used to allow her to use the laser and so on, and the fundus camera and everything. She used to take patients. Today, we have got Remedio camera and others. 4S was actually tested in IIT Madras, and then Remedio, and there are others, which are about 3 lakhs. The quality is as good as any Carl Zeiss or anything. In fact, the US is now importing from India, okay? And across all our 50 branches, we have got it. It has artificial intelligence built in. It can be done by non-technicians, non-ophthalmologists, non-refractionists. A dietitian can do that. Just make them sit, take a picture. Picture is immediately sent to Chennai, to our main office, where the ophthalmologist, we have 7 ophthalmologists. They read it. 30 minutes, they send it to Bhubaneswar or Calcutta, to one of our branches, that is given to our patients. And it makes life so much easy. We tell them whether you need treatment, don't need treatment, whether it's normal, come back after a year. Everything the report says. 30 minutes is all it takes for the report also to be taken. The machine itself takes only 2-3 minutes to get the picture. Whole thing made in Bangalore, okay? And such a fantastic quality. So if they can do that for fundus cameras, just that somebody got into it and they got it done. I'm sure in all aspects of diabetes treatment. You mentioned about the costly drugs. Well, the costly drugs are there, but Indian pharma is so good that very quickly they bring the cheaper versions of that, the generic versions of that, which is 1/4 the cost or 1/5 the cost, and even 1/10 the cost. So that is something where we have think. Insulins, yes, Biocon and many others have made insulins, and I know Kiran Majumdar Shah very well. But the price, unfortunately, is not that much lower than the foreign one. See, if something's come for 150 rupees from a foreign one, if we bring it for 50 rupees or 100 rupees, okay. If there are 150, come for 130 or 140. That doesn't make too much of difference for things. Because insulin, I think the technology is not easy to bring cheap. But these are all windows of opportunity for Indian engineers, Indian technologists, to get together. And with diabetes increasing all the time, I see a huge future. And we can collaborate with you. We can do the clinical trials. We can help you. We can tell you what we need. Then you all must take over and then do that. So one other example I'll tell you. IIT Madras itself, Dr. Valyathan, who as a cardiac surgeon took 1 year off and spent 1 year in IIT Madras, and then became a technologist and developed the Sri Chitra valve. Okay. Now, if he had not spent that 1 year in IIT Madras, leaving his cardiac surgery and then coming to learn, he would not have developed that Sri Chitra valve, which became, it's used in many places. So like this, I think some clinicians have to also learn technology. And I know that IIT Madras is also thinking of starting medical college. I know for sure that Indian Institute of Science has already started, because I'm recently been put on the governing council and on the court. They're getting ready with their MD PhD program and their MD MTech program. So I'm sure such people are going to come who know both medicine as well as technology. People like me don't know technology. That's the whole problem. 2 + 2 is 4, I know. But you ask me 2 + 2.5 + 3.7 and I'll go, because my maths knowledge is so bad right from school. That's why I became a doctor. But there are people who are going to combine all this together, and they are the ones who will be able to solve the problems for us.
I think great perspective. Thanks a lot, Doc. Let me jump into some of the more deeper questions that perhaps haven't been answered. And I know Rajendra and Jivita, your questions are answered. So from Sri Goel, and I suspect this is an either or from a clinician's point of view and a customer patient perspective. Is it the number of cases or the quality of life that matters, or is it the mortality that matters in your experience and opinion?
All of them. Because what is the point in living longer if you have a stroke and you're bedridden, you can add 5 years to your life, where the quality of life is very bad. So we call it as DALYs and QALYs, quality adjusted life years, we say. So as long as you have good quality of life, it is very important. Of course, life expectancy is also important. At the time of independence, our life expectancy was 35 years. Today, it is 70 years, 68 years for males and 70 years for females. Very soon, we'll reach 80 years of age. And you know that age is a non-modifiable risk factor for diabetes. So we're going to get more diabetes just because people are living longer. It's one of the price that we pay. So yes, when I find that my patients have crossed 100 years of age and the quality of life is good, one of my patients wrote a book at the age of 96. Okay. And you know him. He is the former, chief secretary of Tamil Nadu. So there are people like that who at 96 and 98 are still productive, So the quality of life is very good. They're still on their feet. They're still giving speeches. When I called all my 90-year-olds, one of them who was a chief guest was Professor Chitti Babu, who was 100 years old. And he was a chief guest, and he gave the speech, and he conducted the meeting, at the age of 100. So, I mean, what's wrong with quality of life if you can do all that? So, of course, quality of life is very important, but mortality is also important. Now, if we can address it early enough, then prevention is also possible. Prevention, path, reversal, at the stage of pre-diabetes. To prevent them from going diabetes, that is prevention. If you reverse them to stage of normal glucose tolerance, that is reversal. Both are possible. And even if they remain at the stage of pre-diabetes, that itself is good. At least you won't develop kidney, eye, and foot complications. At least 3 complications you can avoid. Although heart, you still have the same risk if in pre-diabetic stage. So in early stages, it is diagnosing early, looking for it early, screening early, increasing the awareness, picking it up early. And at that stage, you don't need medicines at all. You can treat with lifestyle. That is where the lifestyle becomes very important. But you need continuous support and continuous care so that we don't know when they have. See, I'll tell you something about this reversal thing again. People reverse their diabetes. Okay, so some person who might have been on insulin, I could have written. Now he decides to go on some of these programs. I never tell them not to go on the program. Then they come back and they say, my HbA1c is 5.8. I've stopped everything. I'll say, fantastic, keep it up. Come and see me in 3 months' time. I'm not doing anything. You need not be on medicines. Now, the problem is 3 months later, 70-80% of them would have gone to 7.5. And at that time, they don't check because they have convinced themselves that they're cured for life. There is no cure for life. You're only in remission. It's like a cancer. Cancer can go into remission, but we all know it can come back. In my wife's case, it came back after 13 years. For 13 years, we believed she was cured. It came back with meds, and she didn't live even 5 years after that. So like cancer, like psoriasis, like rheumatoid arthritis, like many other conditions, diabetes also can go into remission. It can be for 6 months, 1 year, 2 years, 5 years, but it can come back. Okay. And when it comes back, it can come back with a bang. And the next time you may not be able to reverse it because by the time beta cells are lost. So continuous follow-up is still needed, whatever treatment you're taking, whether you're on diet alone, medicines, insulin, whatever you do, screening for complications and continuous follow-up is needed. That is where the simple technology like the retinal camera I told you and so on helps. So if you do that, then your quality of life is also good because if at all you detect something, you can reverse it back as easily as you found it. You can also reverse it back. In early stages, even complications are reversible. Early retinopathy is reversible. Early nephropathy is reversible. You find microalbuminuria, you can make it normal. You have early neuropathy, you can treat it. But suppose your vision is gone, you've had retinal hemorrhage, or your kidney has gone, now you need dialysis and your creatinine has gone up so high that you need dialysis, or your neuropathy, your leg has become an insensate foot, you're not able to feel anything, then it is too late. You're not able to do. Then your quality of life is only downhill. Okay, then you'll even say, why am I living? Without eye, without kidney, doing dialysis, why am I even living? So that stage we should avoid. in November 2021 for World Diabetes Day, I made an important announcement. I said we are never going to have a diabetes-free India, because 2,000 years ago, 3,000 years ago, diabetes was there. How can I talk about a diabetes-free India when our lifespan is increasing? We'll get more and more diabetes. But you can have a complications-free India. So I said nobody in India should have eye trouble, kidney trouble, heart trouble, foot complications, nerve complications. Nobody should have an amputation. Nobody should be on dialysis. Nobody, if you can prevent heart attacks, good. Nobody should lose their vision. They should have their normal vision, which God gave them. If that you're able to achieve, then I think it is possible. I think it is eminently possible without any rhetoric, without any hype. It's possible. But you need continuous monitoring. And for that also, you need technology. You need apps. You need reminders. You need people to connect. We can't do it. I don't even know how an app is made. Every fellow can make an app. I'm totally stumped by a simple app. I say, how do these guys do it? Because I just don't know. I'm totally ignoramus as far as that is concerned. But for y'all, it's child's play, to produce an app which will take care of diabetic patients on a regular basis. Child's play. Come to us, tell us, and let us develop something which will help people to follow. That will improve their quality of life.
So I'll come to a question from Senthil, which I think you've kind of alluded to earlier, which is methods of glucose detection. It has evolved from urine to blood. What is your view on salivary, and do you think that we will get into some sort of image-based process in time?
We are trying. We are not yet quite there. Salivary, tears, all these have been tried. And I think the difficulty with these is that to get a drop of blood, I don't think is all that difficult. See, if you have to do a biopsy, put in a needle into the liver to get something, a simpler test will help. But when urine and blood can help you to diagnose, to get saliva out will probably be more difficult to do than to get a drop of blood. So if those things come, maybe for children or for somebody else, it may be easier to get. Your veins are gone or something, it may be. But there are other non-invasive things which are coming, like a watch. A glucose watch had come many years ago. Instead of a watch, it tells you your blood glucose level. Okay. We also got that glucose watch. We tried it. What happened was when you sweat in Chennai, it completely goes up, because working on iontophoresis principle. And when you sweat, the whole thing gets diluted and your sugar levels go completely wonky. So you can't make out. But it's coming back. Again, they're talking about things which you can wear. They're talking about things where you just shine a light through your eye and it will tell you your blood sugar level. So they're coming up with newer and newer things. And those things are definitely going to come. There's no doubt that very simple ways of screening are coming. I had a machine where you just put your hand in that. It's a long thing. You just put your hand in that and it will tell you whether you're diabetic or not. About 80-90% accuracy. Unfortunately, to the startup company in California, they closed down. They didn't get funding. They closed down. Just now in ATTD last week in Barcelona, I was there. They have a small spectrophotometric thing. They just shine a light on your skin and they can tell you whether you're diabetic or not. And of course, they checked mine and said, you're not diabetic. And I said, yes, it's correct. So if that comes, imagine, just take a light and shine it on your skin and it's telling you whether you're diabetic or not. So these kind of things, they come from mass screening without drawing a drop of blood. You can do that. And I'm sure those kind of things will come. Alina is asking about infrared glucometer. I think that's the kind of thing I'm talking about. So
same concept, I think, just different vectors.
Applications.
So if we can perhaps spend a little bit of time in understanding once you have late stage diabetes, once you have gangrene, what are the options to treat? Because your degrees of freedom have significantly come down.
There it is more saving the foot, saving the life. See, gangrene means death. Okay, what does gangrene mean? That means some part of it has died. If you have a gangrene of the toe, your toe is dead. If you have gangrene of the foot is dead. You can have a dead body, a dead piece of thing on your body. It will spread and the rest of the body will die. So if you have a gangrene which you don't treat, very quickly it will spread and you will die in a few days' time of septicemia. So the only thing is to remove that toe or remove the leg or remove the foot or remove something which will keep the rest of you alive. You can still give a very good prosthesis and make the person functional. So a lot of research on that, how to make it bionic hand, bionic leg, bionic thing. People are running, Olympic games, they're running with that, with this kind of feet and all that. So suppose it comes to that stage, it's unfortunate. It shouldn't have come. My father also always used to say, why should you go there and then treat? Well, we don't want them to go there, but if they go there, at least must still make them functional after removing their leg or doing something. The eye is more difficult. We become blind using things to read and all that are difficult. Kidney, today we can do a transplant. We can do dialysis and people can still be alive. So even at that stage, there are things which you can do, but the cost goes up. Your quality of life is definitely going to go down. So the earlier you detect it is good, but there is a small market even there for such people. We cannot throw them off and say, oh, you should have come to me earlier. I would have done, now it's too late. No, that unfortunately that person maybe had a different genes set, which drove that person into complications faster than somebody else. I know some of my people who have finished 60, 70 years have not had good control at all. They're just lucky. We can call it karma. You can write writing on your forehead or whatever, or on your palm or whatever. But they're lucky. They simply don't have the genes to develop complications, so they escaped. But others are not so lucky.
So I think we've answered many of the other questions. Pal, your question on digital continuous care has been managed in an offset way. We didn't quite address it
100%
directly.
needed.
So needed, clearly, if we can get that with long-term measurement, it's only good for you. Of course, there are things that you may not want to know 24/7 all the time, because you also want to have peace of mind.
If you do that.
Yeah, correct. Quality of life does matter. I always joke about it that we talked about quality, Dali and Lali. One of the things is there was a long study done in the UK which talked about whether marriage helps people live longer. And they measured this with a very large sample size with the British Army.
It makes it look longer. That's the answer.
No, it's very interesting. So they found that for males, you added 6 years to your life.
Okay.
For females, you added typically 1 year to your life. And the reason is, of course, you will know the answer. Most of the time, ladies lived longer anyway.
Yeah. Correct.
Right? So the difference here is marriage means that you have a reduction in bad habits, especially at the tail end of life. And you're perhaps eating better, you're having more home-cooked food, ... Of course, then came the smart sergeant who came and asked, so was the quality of life any better? And of course, that's a question nobody has raised their hand to measure.
No, but joking apart, social support has emerged as one of the most important things which contribute to increased lifespan, better quality of life. So people who live alone, they don't have social support. For any chronic condition, whether diabetes or asthma, blood pressure, heart or cancer or whatever, they don't do well. Whereas if you have a good social support, whether it is family support or friend support or social circles or something, they do much better. That is very well known.
So I think we have a couple of folks who have live questions and I don't want to put it on the chat. So I think Dr. Dhruva, you clearly have a strong interest. Better be a very good question. You're setting a high bar for yourself. But
so
not
Dhruva Sharma Mithilesh Bareli.
I'm trying to unmute you. I'm trying to figure out how to do that. Maybe moderator, whoever it is, can you allow to do it?
Yes, sir. They can unmute by themselves. So I request Dhruva can unmute.
First, Dhruva, if you can go, and then we'll ask Leena. High bar, huh?
Mithilesh Bareli also. Dhruva?
Yes, sir.
Yes, go ahead.
Apologies, I joined late, sir. I just joined when you were talking about digital gangrene in cases of diabetes.
Okay.
Mohan sir replied that probably amputation of the digit is the way to go and there are many prostheses available. I would like to ask him, like, what proportion of his patients in his clinical practice he comes across this digital gangrene and all, because diabetes has got many microvascular and even major vessels involvement. And do they involve vascular surgeon oftenly?
So if you take all diabetic foot problems, about 70% is pure neuropathic ulcers. You forget about gangrene and start with ulcers. Ulcer only leads to cellulitis. Cellulitis leads to gangrene later. So if you take the early stage itself, the ulcer, just a hole in the leg has formed. And so 70% of that is neuropathy, because neuropathy is much more common in our country. Our published epidemiological evidence shows that peripheral vascular disease of the foot is actually lower than is reported in the West. On the converse, coronary artery disease is much more than in the West and occurs at a much younger age. That we know very well. We don't know why this disparity. Maybe the risk factors are different, whatever it is. And aging also makes a contribution to peripheral vascular disease. And we get type 2 diabetes at a much younger age. That's why they're able to live for 60, 70 years and so on. Now, if the percentage of 70% have neuropathic ulcers, about 20% have neuroischemic ulcers. That means they have neuropathy along with ischemia. And only the rest of them have pure ischemic ulcers. That means having ischemia alone, with blood circulation alone affected, without neuropathy, is not so common. Maybe it's 10% of all the ulcers. But in older people and in long-term diabetes, once it sets in, it's a problem. Because then you have to diagnose it. You have to find methods of increasing the perfusion to the leg to improve the blood circulation. You can do it either with a bypass surgery to the leg, or with medicines, or by putting a stent in, which will improve the circulation. It's still difficult to bring it right up to the toe, because usually in the bigger arteries in the thigh and in just below the knee, you can get it. But when you go into the foot and the very minute capillary type arteries and arterioles, it's not very easy to reach there. How do you reach there to get it? Just by giving medicines, vasodilators, and so on, it doesn't work. And that is where, if the gangrene has already set in, then, as I said, gangrene is death. If you're using the word gangrene, you're accepting that it is dead. Anything which is dead, we are not God to bring it back to life. So if it is dead, it has to go. And therefore, you have to remove the thing. There could be pre-gangrene, which you can save. That means it's not yet dead, you're only dying. That you can still do something. But if it is black and it is totally gangrenous, there is no blood circulation at all, it is totally gone, you have to remove that part, because very soon, within a week, your next toe will go. Within another 2 weeks, your next toe will go. Within another 1 month, your whole leg will go, and you'll end up with you can't just remove the leg alone and leave a foot alone and leave a stump. You have to go below knee. Only then you can give a proper prosthesis. So that is what we are afraid about. But if you see in the 50 years of my practice, that major amputations have come down dramatically. Earlier, 30 years ago, almost every diabetic foot is ending in amputation. Today, it's very rare. Once a year, or once in 1 or 2 in a year, in a big hospital like ours, will end in a below knee or an above knee amputation. The rest of it, we are able to save. 1 toe may go, or 2 toes may go. The rest of the foot we are able to save. So that itself is good, because he still got the foot given to him by God. And on that, he can walk with -1 toe, for which you can give some special footwear to take care of the pressure dynamics. And you can reduce the pressure under the foot. So today, even for that, lot of technology, lot of engineering has come in, kinetics, orthotics, all kinds of new fields have developed there to take off the pressure under the feet. So if you ask me, are you seeing the cases? Yes, we are seeing the cases, a little lower than what we do in the West, but you cannot wish it away and say it will never happen and so on. There are a lot of people with diabetes who are smokers. And in smoking is one of the #1 causes of gangrene. So if you have diabetes and you smoke, then your chances of developing a gangrene go up 4 or 5-fold.
Thank you. Good question, Dhruva. I think
nice
love to
question.
hear about-
Nice explanation, but now there are modalities of treatment available for below knee also. Like people have started approaching through posterior tibial artery and all that.
I'm not saying no, but what I'm saying is, when you go distally, if you come to the to the toe part of it and all that, it's not easy to open up those arteries.
But my point is, we have to probably some vascular intervention might be needed so as to prevent the further progress of the disease. See, diabetes will continue.
Team. Vascular surgeon is part of the team. We do angiograms, we do digital angiograms, we find out the extent of the block. Vascular surgeon is part of the team. Where intervention can be done, we are doing it. I'm not saying we're not doing it. I'm saying, despite that, in some cases, you don't succeed.
Yeah, that is true. Sir, have you done any genetic studies, like what is the reason behind some people developing this gangrenous disease? Because ours is the problem. We have got a huge volume center. I am from SMS Medical College, Jaipur. This is probably the biggest college. If you see the case-wise load, clinical case load is more than AIIMS New Delhi.
Okay, I know.
Right. So we are probably one of the largest vascular. Basically, it is an integrated unit of cardiovascular thoracic surgery, and we see lot of vascular cases. Most of our PVD patients, they are hypertensive, they are smokers, they are diabetics.
Correct.
So we come across them very often, and we see lot of revision vascular surgeries in these patients who have diabetes. Even if see, socioeconomic status is a major concern. People who we mainly come across lower and low middle class in our so
Yeah.
they are
So
not
your point
that
is well
compliant
taken,
to
Dhruva.
drugs and all.
Probably will give a chance to someone else to ask some question. Your point
Yeah,
is very well
Dhruva,
taken. I'm aware of your work and I'm aware of the Jaipur Foot, and I know how much of good work you do. Keep up the good work. We can collaborate. We can take that offline and we can collaborate. But even if you find a gene, what are you going to do? You can't change the gene, no? You can only say some people are more prone to it. And on the research side, it's very good. But practically, what do you do if you find the gene? Nothing much you can do. So let's move on to Mithilesh.
thank you, Dhruva. I think
Sir,
if
I'll
you,
get in touch with you
Yeah.
Please.
through. Yeah.
Dhruva, if
Thank
you
you.
can mute yourself, we just put your email and we'll happily share. That's not a
Yeah,
problem.
definitely.
Mithilesh, your turn. We've got another 3 minutes, so let's.
Yeah, thank you, sir. Good evening to everybody. So I would like Samir sir was saying about lifestyle, and you made a point that most of the diabetic people are smokers, and diabetes is increasing day by day. What kind of category of people are more diabetic? Like you said, smokers are diabetic. Is it because like the smokers are stressed, the stressed population or depressed populations are more diabetic, and how can it be treated?
I don't think that's what he said, Mithilesh, but I think you
He said
misheard
is
it.
a question.
some with
That is a
gangrene or
question that-
smokers. That's what he said.
Okay.
In fact, in the West, there have been some studies suggesting that smoking is a risk factor for diabetes. We have
My-
not found that consistently.
Okay.
Last 20 years, we have been looking for it. Probably the number of smokers is less in India. For example, in Chennai, 17% of the men smoke and women hardly smoke. So, I mean, you cannot claim that diabetes is due to smoking. If at all,
No,
it's a
that
very
is not-
low
that is-
cause.
no, my question is not that. My question is what population are more diabetic? Maybe like teachers, lawyers, or any profession, people who are stressed.
Any profession. I don't think it's related to even doctors are
People
more
who-
prone.
people
Policemen are more
stressed.
prone. Those who put on weight, those who don't exercise, and those who have a family history of diabetes, those are the ones who will get it. Doesn't matter which profession you're in. And whichever profession you're in, you can take care of yourself. If you, if you're a doctor who eats sensibly and exercises and maintains your weight, you can also reduce your risk of diabetes.
Yes, sir. And second question is, how was diabetes treated before allopathy came into existence?
It was treated with some herbs and some things, but first of all, diabetes is not very common those days. I told you 40 years ago, we are only 1%, 2%. Today, we're having 20%. So in the last 50 years is when diabetes has increased. So from the time of Sushruta and Charaka, we've been talking about diabetes. But probably in a city like Chennai, there were 10 cases of diabetes. Today, where there are lakhs of cases, they probably have 10 cases to think. So those 10 cases will be asked to walk and reduce weight and take some herbs, and they will do. At that time itself, Sushruta and Charaka had said that there are thin people who do very badly and they die. They are the type 1 diabetics. They didn't have insulin. Till 1921, every child with type 1 diabetes lived 2 to 3 months. 1 year was unheard of. 2 years was like nothing. It's a miracle, 2 years. Today, they're living 70 years, 75 years with insulin. So certain types of diabetes, only after insulin came, they have started living. Otherwise, they just died in 2 to 3 months, painful deaths, going into worse than any cancer that you're seeing today. But type 2 diabetes is always a lifestyle disease associated with obesity. So they will try to women walk more, reduce weight, eat less rice, eat less thing. They have managed like that and gone on. See, the average lifespan, you must understand, those days would have been about 30 years. Okay. At the time of independence, 35 years. So 1,000 years ago, it could have been 20 years. That's why Shashtitta Purti and all, why people retire at 58. Why? Because 58 now is considered old age those days. When I'm 68 now, I'm looking back and saying, why did people retire at 58? At 68, I'm raring to go. And why are they retiring people at 58? So things are changing. Today, we don't realize how much we have developed, how much our lifespan. In another 10 years, our lifespan will be 80, 85 years. Like in China, you'll be finding a lot of people 110 years old, 120 years old. It's happening due to better lifestyle, better earlier diagnosis, healthier lifestyle, conquering of communicable diseases. We are living in the best of times and the worst of times, as they say, as Charles Dickens puts it.
I have one final question, if you don't mind. I know
Yeah,
we're
yeah, please.
on the dot.
Please,
So, Lena, do you want to ask your question, please?
Yes, sir. Sir, like Akash Manoj have developed a silent heart attack detector for diabetic people, so that they can assess the heart attack before 5 hours, before the injury occurs itself, and in that way we can prevent. But that wearable is 24/7. The diabetic people have to wear it. Do you think the people are receptive to it, like they are ready to wear it 24/7 if in case that helps them to prevent heart attack, because they can't sense the chest pain like other normal people.
Yeah. So, Lena, it's a good thing. And I know that, wearing an Apple Watch, for example, has saved lives. There are documented cases in the literature where somebody picked up an arrhythmia and then went into an ICU or went into the emergency. And they said, yes, your watch has picked it up properly. They're immediately given treatment for it, and it has saved lives. But more often than not, errors come in this when you're wearing it all the time. So wearing it all the time to detect a heart attack, imagine how many people will get a heart attack. 1,000 people wear it. One person may develop a heart attack in that. The other 999 are always worrying about the heart attack. That may produce a heart attack, wearing it all the time and being worried about it. So I don't think you should take precautions for it. No smoking, sleep on time, enjoy yourself, be happy, eat more fruits and vegetables, watch your weight, don't drink in excess, control your diabetes, control your blood pressure, do yoga, do pranayama. This is the way to prevent heart attacks, not a watch. Oh, watch, I'm going to prevent heart attack. It may help 1 in a million person, and that will get blown up in papers and all that. But that's not how all heart attacks are prevented. Same person who asked question, how were the diabetes treated before allopathy came? How were heart attacks prevented before the Apple Watch was created? So people lived their life. So these are technology which you can use, but remember that a lot of paranoia can come. I know people, when COVID came and this pulse oximeter came, half the time the pulse oximeter doesn't work. I've tried it in one finger, and another finger give completely wrong. 98 in one and 92 in another, and 84 in another. 84 I should be in ICU, and the same finger, same machine. If you try another machine, it'll show me 78. Next one I'll try, it'll show 98, So this is how it is. It's so much of variation and so on. Not all these technologies are completely foolproof. So we shouldn't become completely technology dependent so that our whole life is going only according to technology. Use it when needed, because these are things which you should use. It's like a phone. You use a phone when you need it. If all the time, if there's 1 hour, if I've taken my phone and looked at it while I'm talking, that means I've got addicted to it. I need to detox, and then do that. So all these are meant to help you, and where it helps and where technology helps, you should do that. But today there's a move that doctors are not needed and you can diagnose everything. I feel Google universities and WhatsApp universities and Apple Watch universities have their own dangers, because you overdiagnose, you don't understand what it is, and there is a big danger that you can misdiagnose something and you think that you know everything, whereas we all study 10 years and we think we know nothing after that. Whereas somebody reads in Google something and they think they know everything, and they're questioning the doctor and so on. I think humility is what is needed. Still trust your doctor, because they have some experience, and so trust them. It doesn't mean that you cannot share your blood sugar readings or your blood pressure readings with your doctor. It's going to help your doctor. But a doctor and a human being is still needed to take decisions regarding medicines and so on, because a lot of other factors which AI may not understand. And first of all, AI is not going to, pat you on the back and tell you, empathy is not going to come from AI. There are certain things, just like we talked about lifestyle, a doctor empathizing, holding the hand of somebody and saying, you're going to be all right, is much better than any AI can tell you. So while we can use all this technology, let us not forget the tender loving care and experience of a doctor is also important. I think it's marrying all this, using it where needed, which is going to be there. Nothing in extreme should be done.
Thank you,
Sir,
Dr.
thank you, sir. And I have only one small question. Like in my research area, have read so many articles. Recently, people are using a drug called Fisetin, and it was helping in all his ischemia, heart disease, injury, and all. Since it's a antioxidant. But Fisetin naturally available in fruits like mango, grapes, strawberries. But diabetic people can't take it. The fruits they can take, I didn't see Fisetin is there. So in these kind of situations, can't they take some fruits because that does help them in, like, it can reduce their cholesterol buildup. They can, it can
Watch
reduce
my
the
videos
CVD risk.
on fruits. I have at least 4 videos on YouTube where I'm saying mango can be taken by people with diabetes. I have separate
Okay.
one on fruits. Fruits have a lot of antioxidants and you can take it. And it's funny that you talked about Fisetin, because yesterday my PhD student Srividya, her topic was on Fisetin, and she's done a lot of work. Were you there for the PhD?
Yeah.
Yeah. So we talked
Yes, sir.
about it, isn't it? And you might have heard me say at the end of the PhD that clinical trials have to be done and we have to work on it. So there's a lot of things which can be done, but then science develops by doing proper randomized clinical trials, finding the proof. Sometimes what you see in an experimental situation will be totally opposite when you do a clinical trial. So we have to do clinical trials, and science, that is why science takes time. Step by step only science moves, not in like just 5 moves ahead you go. You can't do that in medicine because you're dealing with human beings. And so we have to do that. So not only Fisetin, but there are many other compounds which are probably there, but they all need rigorous trials before they can be introduced into. You're dealing with human beings, human lives. So we don't want any side effect. We don't want anything, some unexpected side effect may come. So all that is part of the rigorous clinical trials which these drugs have to go through.
Sir, can you tell like what fruits diabetic people can take? Like,
Apple, papaya, guava, these are all fruits which you can take. If mango is your favorite and that's the season now, take it, but take a little less of it. Cut down your carbohydrate or rice you cut by half and replace it with mango, or take the mango in between your meals. So as I said, there are videos, 2-minute, 3-minute videos of mine. Just go to YouTube, and I've talked all about fruits and so on. Okay.
Okay. Thank you, sir.
Thank you. I think we've passed the thing, and we've had extreme kindness from Dr. Mohan. So first of all, Dr. Mohan, thanks for taking us through a journey from the early days of measure through outcome by looking at the amount of sugar in a urine, to perhaps looking at the future where perhaps from input parameters we might be able to detect diabetes and suggest risk factors. And more importantly, going through some of the journey of whether it's who are more likely to have diabetes, to what are the more likely treatment protocols, to some of the ideas I think people on this call, especially from IIT and entrepreneurial talent, should really look at. Can you make a patch that perhaps can last a year?
Yeah.
Because that would be really useful. May not need to do sampling rates of X thousand per day. It might be fine to do just X 100 per day, or not even that many. Maybe 30 or 1 per day is actually good enough for 90% of people or 99% of people. I think the other thing is, take the doctors seriously. There is a reason you go to a doctor, for getting a holistic point of view.
Yes.
Make sure the credentials of a doctor, the same as you go to an NABH accredited hospital.
Okay.
For those who don't know what that means, please look it up. We buy branded goods because we trust them. There are systems and accreditation standards that evaluate quality of people, just like you look at gold standard, whether somebody studied at IIT versus the Indian Institute of Telangana, perhaps, and no disrespect to Telangana, but it may not even be an IIT, but somebody has copied the name.
Yeah.
I still remember one of the very early venture projects that had come through, and it had an IIT student on it, which called itself Robo Diabetes. And so I asked them, what made you choose a name like Robo Diabetes? And all they were giving was a sugar pill that kind of like temporarily held your diabetes level. So they used to give it to people and say, now you measure your sugar and you'll see a difference and a change. We've cured diabetes. And I was there looking at these guys thinking, seriously, this is the quality of people coming. So I think take it seriously, talk to experts. I think one of the best pieces of advice Dr. Mohan gave here was the capacity for clinicians to spend more time in technology, the capacity for technologists to spend more time with clinicians. I think at HTIC and at IIT Madras, you can do a combination of both.
Yes.
So for those of you who are joining from far and wide, please do come and participate in HTIC. It's one of the best incubators around. It's one of the best accelerators around. And I think for those of you who are still keen to hear Dr. Mohan, I'm sure he takes consults. And more importantly, if you become a PhD student of his, he'll even do it for free. So I think with that, thanks a lot, Dr. Mohan. Thanks
Thank
a
you.
lot, Team HTIC. I think Muthu and team, fantastic job. And Mohan and many of the other rock stars, Mohan Shankar and folks at HTIC, I think you got some wonderful resources. Please use them. I think we look forward to seeing entrepreneurs that crack the next generation of cures and tests and diagnostics and perhaps treatment protocols that might far exceed our expectations. And remember, we stand on the shoulders of giants, as Dr. Mohan said. You will stand on the shoulders of giants. Perhaps you won't appreciate that they're giants today. So leverage the wisdom. And I think, thank you.
Thank you so much.
you,
I think
sir.
you have summarized it very well. And in 1 hour, that's all we can do. And if we have to continue this, conversation until we really serve society, that's why I gave one positive thing about the fundus cameras which were developed. And that's not an easy thing to do. And it was so beautifully done that it's changed the way fundus photography is done. And similarly, for all other things, we can find local solutions and which can come at a much lower cost and making it affordable to our population. And we are here, let this conversation continue. If there are more opportunities to continue discussions like this, we'll be happy to allot more time. And so wish you all the best. But most importantly, I think the young minds, we want to, have a positive approach and then, think of serving society. And the money will come. The money will come ultimately. Don't make money as your primary thing, but make serving society and contributing to cause as your main thing. The money will just flow after that. So if everybody is interested to fund a good.
No, I think excellent wisdom. And for those of you who are more interested in the technology side of some of these care protocols, the Kahotech, which HTIC has been very active with, which is the consortium of accredited healthcare organizations. We've had some great suggestions in the past and technologies that have been commercialized through that. That's a great one. It's online this year. For those of you who want investment, the Pitch Fest is there. Who are looking for healthcare partners. I think this year it's in IIT Mumbai. So I think that's a great platform. For those of you who are in healthcare and want to talk to each other to cross-collaborate, like Dr. Dhruva had suggested, there's organizations, the Association of Healthcare Providers of India, that have done some fantastic work with all of us, and many of us are involved in those. So I think thanks, look forward to it. And more than anything, I hope this talk has spurred your interest in being more innovative tomorrow than yesterday. And remember, our purpose is to make sure tomorrow is better than yesterday. The journey is yours. Thank you.
Very well put. Thank you so much.
So
Bye-bye.
thank you. So
Bye.
thank you, sir. Thank you, Dr. Mohan, and thank you, Dr. Sameer, for spending your. I think he left the meeting since he has another call at 6:30. So thank you, sir, for sharing the session and for sharing it brilliantly. I would like to thank you once again for spending your time from your busy schedule. So thank you, sir. So I would request the participants to fill the feedback form for the sessions which we will be conducting in future to know how the sessions were. So we have shared the feedback form link in the chat box. And thank you the participants for joining the session.
Thank you.
Thank you, sir.